For this module, we will focus on different types of personality disorders in clusters A, B, and C. We will discuss the risk factors for such disorders and the common expected findings. We will also review the nursing care, communication strategies, and treatment modalities for clients who present with personality disorders. What is personality disorder? Personality is a word derived from the Greek term persona. It was initially used to describe the theatrical mask some dramatic actors wore at the time. Personality traits may be defined as characteristics that an individual is born with or develops early in life. They influence the way in which he or she perceives and relates to the environment and are pretty stable over time. Variables in development include, but are not limited to, heredity, temperament, personality, mood, traits that determine how someone reacts to the world, experiential learning, and social interaction. Recent research on the psychobiology of human personality conducted through person-centered, functional brain imaging has broadened our understanding of healthy personality development and the factors that contribute to individual differences. Many theorists have attempted to organize information about personality development. Most suggest it occurs in an orderly, stepwise fashion. However, the stages overlap as maturation occurs at different rates in different individuals. Most people with a personality disorder show impairments in self-identity. They can also have other mental health disorders, also known as comorbidities. They may include depression, substance use, and, most commonly, anxiety. The risk factors for personality disorders are complex. They are not limited to one specific risk factor, such as genetic or biochemical factors. They may involve the interaction with the environment or social determinants of health. People may also have experienced exposure to substance use and sexual or physical trauma, especially during childhood. Personality disorders are divided into 3 categories. Cluster A consists of odd or eccentric behaviors. Cluster B consists of dramatic, emotional, or erratic behaviors. Cluster C is about anxious or fearful behaviors. It is very important to remember this classification. Below is a visual of different personality disorders in clusters A, B, and C. Please, keep it handy, as it will help you to remember the classification without memorizing them. Individuals with paranoid personality disorder, which is part of cluster A, are constantly on guard, hypervigilant, and ready for any real or imagined threat. Appear tense and irritable. Have developed a hard exterior and become immune or insensitive to the feelings of others. They mistrust other people. They always feel that others are there to take advantage of them, and any perceived slights, injuries, or insults become long-held grudges. They are extremely oversensitive and tend to misinterpret and distort even minute cues within the environment into thoughts of trickery and deception. We are constantly testing the honesty of others. Clients with paranoid personality disorder do not accept responsibility for their own behaviors and project this responsibility onto others. They are envious and hostile toward others who are highly successful and believe the only reason they are not as successful is because they have been treated unfairly. They are extremely vulnerable and constantly defensive. The desire for reprisal and vindication is so intense that a possible loss of control can result in aggression and violence. Studies have revealed a higher incidence of paranoid personality disorder among relatives of individuals with schizophrenia than among control subjects. Psychological predisposing factors, as is the case with many personality disorders, include a history of childhood trauma, including neglect. Such people may have been subjected to parental antagonism and harassment. They learn to perceive the world as harsh and unkind, a place calling for protective vigilance and mistrust. Schizoid personality disorder, part of cluster A, is characterized primarily by a profound defect in the ability to form personal relationships. Others often see them as eccentric, isolated, or lonely. These individuals display a lifelong pattern of social withdrawal, and their discomfort with human interaction is apparent. The prevalence of schizoid personality disorder is difficult to ascertain. Estimates of its prevalence within the general population vary between 3 and 5%. Significant numbers of people with the disorder are never observed in a clinical setting. Gender ratio of the disorder is unknown, although it is diagnosed more frequently in men. People with schizoid personality disorder appear cold, aloof, and indifferent to others. They typically have a long-standing history of engaging in primarily solitary activities or engaging more with animals than people. They prefer to work in isolation and are unsociable. They are able to invest enormous affective energy in intellectual pursuits. In the presence of others, they appear shy, anxious, or uneasy. They are inappropriately serious about everything and have difficulty acting in a light-hearted manner. Their behavior and conversation exhibit little or no spontaneity. Individuals with schizotypal personality disorder display odd and eccentric behavior, which are typical cluster A behaviors, but not to the level of schizophrenia. Schizotypal personality is marked by symptoms that look more like schizophrenia than those in schizoid personality and as such, show significant peculiarities in thinking, behavior, and appearance. Studies indicate that schizotypal personality disorder has a prevalence of around 4% and more than one-half of these individuals have had at least one episode of comorbid major depressive disorder. Individuals with schizotypal personality disorder are aloof and isolated and behave in a bland and apathetic manner. They often talk or gesture to themselves, as if living in their own world. Symptoms include magical thinking, ideas of reference, illusions, and depersonalization are common. Examples include superstitious beliefs, belief in clairvoyance, telepathy, or sixth sense, and beliefs that others can feel my feelings. For cluster B, the most common type of personality disorders include antisocial personality. It is as a pattern of socially irresponsible, exploitative, and guiltless behavior that reflects a general disregard for the rights of others. These individuals exploit and manipulate others for personal gain and are unconcerned with obeying the law. Also, people with antisocial personality disorder have difficulty sustaining consistent employment and developing stable relationships. It is one of the oldest and best-researched personality disorders. In the United States, the prevalence is estimated to be about 3% in the general population, but in prison populations, the prevalence is 50% or higher. It is more common in men than women, among the lower socioeconomic classes, particularly among highly mobile inhabitants of impoverished urban areas. Histrionic personality disorder is characterized by colorful, dramatic, and extroverted behavior in excitable, emotional people. They have difficulty maintaining long-lasting relationships, although they require constant affirmation of approval and acceptance from others. They often engage in seductive, flirtatious behavior to reassure themselves of their attractiveness and gain approval. People with histrionic personality disorder often demonstrate, to an extreme, what our society tends to foster and admire in its members: to be well-liked, successful, popular, extroverted, attractive, and sociable. They tend to use their physical appearance as a means to draw attention to themselves. However, beneath these surface characteristics is a driven quality, an all-consuming need for approval and a desperate striving to be conspicuous and evoke affection or attract attention at all costs. Failure to evoke the attention and approval they seek often results in feelings of dejection and anxiety. Individuals with this disorder are highly distractible and flighty by nature. They have difficulty paying attention to detail. They can portray themselves as carefree and sophisticated on the one hand and as inhibited and naive on the other. They tend to be highly suggestible, impressionable, and easily influenced by others. They are strongly dependent. Interpersonal relationships are fleeting and superficial. Interaction with others tends to be provocative or sexually inappropriate. They tend to misinterpret relationships as more intimate than they truly are. Another well-researched cluster B personality disorder is narcissistic personality disorder. These people have an exaggerated sense of self-worth. They lack empathy and are hypersensitive to the evaluation of others. They believe that they have the inalienable right to receive special consideration and that their desire is sufficient justification for possessing whatever they seek. The prevalence of narcissistic personality disorder is estimated at 1 to 6%. It is diagnosed more often in men than in women. Individuals with narcissistic personality disorder appear to lack humility, being overly self-centered and exploiting others to fulfill their own desires. They often do not perceive their behavior as being inappropriate or objectionable. Because they view themselves as superior, they believe they are entitled to special rights and privileges. If they do not meet self-expectations, do not receive the positive feedback they expect from others, or draw criticism from others, individuals with narcissistic personality disorder may respond with rage, shame, humiliation, or dejection. They may turn inward and fantasize rationalizations that convince them of their continued power and perfection. The exploitation of others for self-gratification results in impaired interpersonal relationships. Although causes are unknown, psychodynamic theories have suggested that narcissistic personality disorder evolves from a parent-child dynamic of either excessive pampering or excessive criticism. Narcissism may also develop from an environment in which parents attempt to live their lives vicariously through their child. They expect the child to achieve the things they did not achieve, possess that which they did not possess, and have a life better and easier than theirs. Borderline personality disorder is characterized by a pattern of intense and chaotic relationships, with affective instability and fluctuating attitudes toward other people. These individuals are impulsive, are directly and indirectly self-destructive, and lack a clear sense of identity. Prevalence of borderline personality is estimated at 1 to 2% of the population, with impairment being frequent, severe, and influencing, and characterized by job losses, education interruptions, and marriage breakups. It is generally estimated to be twice as common in women as in men. Historically, there have been a group of clients who did not classically conform to the standard categories of neuroses or psychoses. The designation borderline was introduced to identify these clients who seem to fall on the border between the two categories. Other terms that have been used in an attempt to identify this disorder include ambulatory schizophrenia, pseudoneurotic schizophrenia, and emotionally unstable personality. These individuals seem to be in a state of crisis and have frequent mood swings. Their affect is one of extreme intensity, and their behavior reflects frequent changeability. These changes can occur within days, hours, or even minutes. They are sometimes described as thriving on chaos, since their behaviors frequently generate chaos, particularly in interpersonal relationships. Let us now discuss Cluster C personality disorders with anxious or fearful behaviors. For example, the individual with avoidant personality disorder is extremely sensitive to rejection and, because of this, may lead a very socially withdrawn life. It is not that he or she is asocial. In fact, there may be a strong desire for companionship. The extreme shyness and fear of rejection, however, create a need for unusually strong assurances of unconditional acceptance. The prevalence of the disorder in the general population is about 2 to 3%, and it appears to be equally common in men and women. Individuals with this disorder are odd and uncomfortable in social situations. From a distance, others may perceive them as timid, withdrawn, or perhaps cold and strange. Those who have closer relationships with them, however, soon learn of their sensitivities, touchiness, evasiveness, and mistrustful qualities. Dependent personality disorder is characterized by lack of self-confidence and extreme reliance on others to take responsibility for them. Individuals with this disorder tend to allow others to make decisions, to feel helpless when alone, to act submissively, to subordinate needs to others, to tolerate mistreatment by others, to demean oneself to gain acceptance, and to fail to function adequately in situations that require assertive or dominant behavior. They lack of self-confidence that is often apparent in their posture, voice, and mannerisms. They are typically passive and acquiescent to the desires of others. They are overly generous and thoughtful and underplay their attractiveness and achievements. They may appear to others to be happy, but when alone, they may feel pessimistic, discouraged, and dejected. Others are not made aware of these feelings. People with dependent personality disorder assume a passive and submissive role in relationships. Should the dependent relationship end, they feel fearful and vulnerable because they lack confidence in their ability to care for themselves. They may hastily and indiscriminately attempt to establish another relationship with someone they believe can give them the nurture and guidance they need. Psychosocially, dependency problems may arise when parents become overprotective and discourage independent behaviors. Dependent behaviors may be subtly rewarded in this environment, and the child may come to fear a loss of love or attachment from the parental figure if independent behaviors are attempted. People with obsessive-compulsive personality disorder tend to have a serious and formal demeanor and have difficulty expressing emotions. They are overly disciplined, perfectionistic, and preoccupied with rules. They are inflexible about the way in which things must be done and have a devotion to productivity to the exclusion of personal pleasure. An intense fear of making mistakes leads to difficulty with decision-making. The disorder is relatively common and occurs more often in men than in women. Within the family constellation, it appears to be most common in oldest children. Please note that recurrent obsessions and compulsions are absent in this personality disorder, and if the client presents with such symptoms, they are diagnosed with obsessive-compulsive disorder rather than obsessive-compulsive personality disorder. This is the crucial difference between the two. Clients with obsessive-compulsive personality disorder are inflexible and lack spontaneity. They are meticulous and work diligently and patiently on tasks that require accuracy and discipline. They are especially concerned with matters of organization and efficiency and tend to be rigid and unbending about rules and procedures. They tend to be solicitous to and ingratiating with authority figures. With subordinates, however, the compulsive person can become quite autocratic and condemnatory. Although on the surface, these individuals appear to be calm and controlled, underneath this exterior lies a great deal of ambivalence, conflict, and hostility. Individuals with this disorder commonly use the defense mechanism of reaction formation. Not daring to expose their true feelings of defiance and anger, they withhold these feelings so strongly that the opposite feelings come forth. When providing care to clients with personality disorders, as a nurse, it is very important to do a self-assessment. This helps with how you interact with them therapeutically and helps you maintain professional relationships. You can repeat such an assessment several times as the client's behaviors change. As you interact with clients, they may sometimes feel threatened. Nevertheless, maintain professional boundaries all the time. For example, apply limit setting and consistent with clients in cluster A and even B, clients who tend to exploit healthcare professionals, such as those with borderline personality, antisocial and paranoid personality disorders. Use a firm approach but remain supportive. If it is safe to do so, allow them to isolate for a while. Most personality disorders do not require medication therapy. However, psychopharmacology may be helpful in some instances. Although these drugs have no effect on the direct treatment of the disorder itself, some symptomatic relief can be achieved. We can use medications, especially SSRIs, for clients who develop obsessive-compulsive personality disorder, which may become recurrent or repetitive. Other medications, such as anxiolytics, are just used temporarily to manage anxiety in the short term. Basically, we target symptoms and not necessarily the personality disorder. Different types of therapy are highly recommended for personality disorders. Individual psychotherapy. Interpersonal psychotherapy may be particularly appropriate because personality disorders largely reflect problems in interpersonal relationship skills. Milieu or group therapy. This treatment is especially appropriate for individuals with antisocial personality disorder, who respond more adaptively to support and feedback from peers. Cognitive behavioral therapy. CBT. This therapy helps the client recognize and correct distorted and irrational thinking patterns. Dialectical behavior therapy. It is effective for the chronic self-injurious and parasuicidal behavior of clients with borderline personality disorder. It is rooted in a belief that the primary problem for this client is emotional dysregulation. It is a complex, eclectic treatment combining cognitive, behavioral, and interpersonal therapies with Eastern mindfulness practices. Below is a visual of how a parking lot can be used to illustrate different personality disorders. It can help clients develop a perception or insight into how their personality disorder may influence or dictate their parking preference. Thank you for reviewing this module till the end. Enjoy the rest of your day.